why are we missing the huge piece in the front half of our body? Really overall in our education, right? As PTs, we're not really taught on how to assess the motility of the abdominal wall. These are basic concepts that can be easily taught, but with hernia repair, 25% of men will have an inguinal hernia in their lifetime. But if they're getting an inguinal hernia, why are they not getting in? Because they have dysfunctional breathing pattern, paradoxical breathing pattern. Coming in for prehab would be an open market for us to educate the patient on what to expect from the surgery.
Up next, we're thrilled to welcome a pioneer in the field of pelvic health who's helping bridge the gap between orthopedic manual therapy and pelvic health pain management. Dr. Kelli Wilson is a physical therapist, educator, and the founder of Alcove Pelvic Health Education. Through her company, Kelli trains PTs and OTs to address complex pelvic pain conditions in both men and women. And she also treats these conditions in her clinic in Austin, Texas. Kelli has been instrumental in normalizing the discussion of pelvic health within AAOMPT, even starting the Pelvic Health Special Interest Group. In today's conversation, we'll explore her work in combining orthopedic techniques with pelvic health interventions, particularly for male patients experiencing testicular and pelvic pain. We'll also discuss how manual therapists can expand their practice to address these underserved areas, enhancing patient outcomes. Don't move. This is Hands On, Hands Off. Kelli, welcome to the podcast.
Thank you.
How's your AAOMPT so far?
It's been awesome.
I'm just going to bring this a little closer.
Okay.
Say that again. It's been awesome.
It has been awesome.
There you go. So you're a little different here at AAOMPT.
Yes.
Your work focuses on merging orthopedics and pelvic approaches.
Yes.
And I remember one of the very first podcast episodes I did back in 2015. It was with a pelvic therapist because I said, I don't know anything about this. We haven't covered this yet in PT school. I was still a PT student. And she said, pelvic health is orthopedics in a warm, dark place.
Yeah.
And that has never left my brain. So how'd you first realize there was a need to integrate these two things together?
Interesting. I had started working in a clinic in Central Texas, and that was one of the only one out of two or few clinics that had a full-time pelvic floor therapist 15 years ago. Now there's full-time pelvic health therapists a lot of places, but I was exposed to pelvic health because of the owner that was already very passionate about it. I was going through my fellowship at the time, getting orthopedic training, and I was getting that really strong foundational background, but the pelvic health therapist at that clinic had a patient with tailbone pain. And she was like, I don't do any kind of internal manipulation back there. So you need to take this patient since you're going through your fellowship.
You're like, okay.
So I took the patient, and she had pain for 20 years sitting. She had not been able to sit on a hard surface chair for 20 years. And she was very disabled, functionally because of that. She had fallen on her butt, her tailbone, so it was completely flexed backwards. So she really, truly did need what we learned in PT school, the internal manipulation for her tailbone. So I'd hate to admit this, but I was like, I read up on it. I hadn't actually done it, hadn't gotten the training. But back then, you had to do that treatment. So anyways, I performed the internal manipulation. She got up, and it was one of those aha moments that doesn't happen all the time as a clinician, but she was like, I can sit. And then the next time she came in, she's like, the pain that I've had for 20 years is gone. And I was so shocked with the internal rectal manipulation and like, I don't know if I can do this, and fearful. But what a powerful piece of a treatment that was just only 2 to 3 minutes and changed this person's life.
2 decades.
2 decades. And so I was like, this is amazing that I can help people. And I started taking the courses, and then really evolved. And I have an education company now where I converged orthopedic components, because back when I started it in 2015, it wasn't converged. And so just pulling in together what I'm speaking about at the conference tomorrow morning is basic orthopedic approaches for testicular and penile pain, where you don't have to be fearful as a clinician to know, if you know the pathology or the pathway for nerves, muscle influences, you can do a lot of successful treatment,
really change days and lives and
yes.
Right?
Yeah, because everyone's very fearful about the genitalia.
Sure.
And, I understand, but there is a comfortability that we all can have if we are the best clinicians in the world, if we are fellow trained.
Right.
that we need to have a basic concept of.
I was told early in PT school is something will be awkward if you make it awkward in terms of the clinician, right? If it's awkward for you, the other person can tell. The patient can tell. The person standing in the room can tell. Since you do education on this, where do you start sort of removing that? You said people have, maybe issues or, it's a little awkward when we start talking about genitalia. How do you teach removing that, or where do you start with that? That's got to be in the syllabus, right? Because that's a big component.
Right. Well, it's looking at it very matter of fact, right? This is a functionality. Sex is an ADL. These are part of things in every person's life. And so breaking that down and not being fearful, a horse smells fear, right? So you have to have confidence. And even as we come out of PT school, we have lacking confidence, but you got to go into that room. My first rotation, my CI, he was like, here you go. It was a complex low back pain. He's like, you only learn. Right. I didn't even get to watch him. Wow. It was horrible, but you have to exude confidence. Now you have to have some knowledge and not just act like you know everything. But it's just building that foundational background and having that confidence, because people are going to talk to you if you're directed. And I was just talking to a colleague. I'm like, if you're talking about and asking questions with your patient about intercourse, but they're coming to you for low back pain, and you're like, do you have any testicular pain, or do you have, why am I asking these questions? Because a patient would be like, why are you asking these questions? Well, you explain, you show something that's structural, the spine, or explain, okay, look, you come here for back pain, where your pain is, the nerve levels that are coming out at that level also supply, the testicles, or provide sensory, and you're also having these symptoms. So I need to ask these questions. And you make it very matter of fact, and then they get it. Yeah. And they're not like, oh my gosh, why is this therapist asking me all these questions?
I remember in my very first was an outpatient orthopedic rotation. I had a female CI and a male patient who, I forget his injury. He had broken something and he was healing, right? So we're talking about bones. Mm-hmm. So my brain was very much on bones. And it was the third or fourth visit. I remember he was acting a little squirrely, and I couldn't figure out why. Whatever we did, we set him up. I was staying with him, the patient, and my CI was leaving. And the second she left, he was sort of craning his neck, and he said, I need to know what positions I can do. And I'm like, what are we talking? I'm like, I literally said, well, laying on your back, supine is good. I had no idea what we were talking about, right? Because he was there for a fracture, whatever, a leg or something. Yeah. And he was like, before she gets back, I want to ask you, because and I'm like, but it took me 3 questions before I knew what he was talking about. He was talking about sex positions. Yeah. Which ones are okay to do? I think it was a knee. I think that was the issue. It was a knee. Mm-hmm. And all of a sudden, a light bulb came on, and she was coming back, and I said, I'll figure it out in a second. And what I was trying to tell him is, if you're uncomfortable asking in front of her, cool. Yeah. I'll get you the answer, and I'll give it to you when she's not around again, I guess, if that's the thing. But that was the first moment I said, oh, we're being looked at like a source of information at something they might not know how to Google like they could, but they wanted to ask a professional. And that was the light bulb moment. I was like, but you're here for a knee. Why are we talking about sex? But, if the knee's injured, that's an issue. And
who else are they going to go to? I mean, that is our potential market, right? Sure. I mean, that is our prime market. And there is a huge crater of blackness for this population, a gap, right? Like what I was talking about with testicular and scrotal and groin pain, is that there's 100,000 cases per year in the U.S. with cisgender males or men that have that. 50% are undiagnosed, undetermined, because they don't have organic or biological factors. It's not due to infection. It's not due to tumor, due to cancer. And that is probably due to musculoskeletal origin. But the research is lacking so much on conservative measures for testicular and scrotal pain anyways, that there's not any literature on the musculoskeletal causes. But that is priming us as physical therapists to really dive into that field and help those patients, because that's not being talked about. They don't know where to go. And why not us be the experts for that?
Yeah, if there's a gap, that's good. That's opportunity. If you're going to do a SWOT analysis, that's an opportunity to say, okay, well, there are people with this problem that is within our scope. We can do this. Right. We have to get over ourselves first, right? That's the first step. That's why you're speaking at an event like this. So what are some key orthopedic techniques that manual therapists can use to address male scrotal injuries?
Male, female, vulvar. Okay, so let's think about this, okay? The sympathetic nervous system supplies the pelvic things. from levels T10, L1, L2. So thinking upper lumbar, lower thoracic. And in the male population, we know that posture doesn't really play a huge key role. We're like, oh, you have this hyperlordosis posture, this is causing your back pain. We know that you can have these variants, but some extremes can lead into issues, right? Extreme postural habits can lead to some problems. But and if you think about men that like work out, that are very stealth, they have that crazy lacking mobility too, lordosis, but lacking mobility in the mid-thoracic region. So some simple techniques can be looking at how does their posture move, active range of motion in the lumbar spine, simple, but maybe get it loaded in quadruped. Look at how the TL junction's moving in quadruped, in cat-camel position, because is there gross negligence or lack of mobility in a certain extreme? Easily, you can mobilize it right there into a moving mobilization in that position. You can give them education to get more movement, because maybe they're biasing it into the mid-thoracic or lumbar or whatever. You can educate that. That's easy. You can look at the hips. Look at hip mobility. Simple hip mobilizations have the biggest connection with the pelvic floor muscles. Because if you think the deep hip external rotators tie in shared fascial components with the pelvic floor muscles. And the pelvic structural aspect of a male pelvis is the outlet is the inferior portion of the pelvis. It's more narrow. I wouldn't say it's tight, because that's just the way you guys are. It's pretty normal, but there's not much mobility. So what normally is the most restricted in male hip mobility?
Hip flexors.
Hip flexors and then hip internal rotation, right? As they age, right? Like the osteoarthritis, they lose that internal. So if they lose internal rotation, then they're not getting full mobility to their external rotators. They freeze up like an iceberg, kind of. Mm-hmm. They're not getting mobility to their pelvic floor muscles. So basically, long story or long answer is basic lateral hip distraction. You're playing with the pelvic floor muscles and increasing and normalizing mobility in that area.
But Kelly, everything you've talked about, these are orthopedic things.
Yeah.
Right, but it's where you're treating. So you don't necessarily need to be treating specifically the area where the pain might be, and we know that. We know that. But I think when people hear, myself included, pelvic physical therapy, they think, you have to put your hands places that are going to be, eyebrow raising. Yeah. But the two or three you just mentioned there, none of those. Those were thoracic, lumbar, and rotators at the hip.
Yeah, right. So it's just pulling in that big picture to be like, as a clinician, have that aha moment and be like, I can totally be successful with treating a patient that comes to me with testicular pain by doing these approaches that I have confidence in doing as an orthopedic manual physical therapist. Yeah. Not to discount the importance of training in pelvic health, or if it's applicable to get referral out to a pelvic health therapist. But this is basic foundational stuff, and this is information that needs to be in the fellowship programs, that I'm an advocate for, because it's pretty easy, right? Yeah. It's our bread and butter.
Yeah. You told the story about the woman who couldn't sit for 20 years, right? What are some, because now you educate people, what are some of the aha moments you've heard from students that they go out and they treat a patient? Is there any one story that someone couldn't do this or was living with this, and because of something simple or fundamental that the therapist was able to do, you changed a life?
Great question. I know. I feel like sometimes my students have these better aha moments because I'm like, I want to have that. I deal with complex pelvic pain patients, so it's never like a easy one stuff. But they, something easy with like butt clenching. Looking at someone standing and they have tailbone pain, like the easy looking at functional capacity, like are they standing or sitting all the time 100% with their butt cheeks on, and then allowing the pelvic floor muscles to relax. Something so simple like that can have an overflow. I'm just thinking of something
simple for someone who knows what they're looking for, but not necessarily the person who might be doing it or understanding what their problem is.
Right.
Prehab is not something I think that I would have ever put with pelvic issues, but prehab and rehab for joint replacements or other orthopedic is pretty common, but less so for pelvic conditions like hernias. Yeah. Is that something that we should be paying attention to? Prehab for a hernia operation?
Yes. Okay. So if we're looking at, and we have research to validate prehab for prostate, we need more prehab for prostate removal. That's a big one that needs to be further developed as well. But yes, for knees, why are we missing the huge piece in the front half of our body? I mean, really overall in our education, right? As PTs, we're not really taught on how to assess the motility of the abdominal wall,
right.
looking at inguinal ligament texture changes or extensibility. These are basic concepts that can be easily taught. But with hernia repair, 25% of men will have an inguinal hernia in their lifetime. And the main key thing was, why is that happening? Why are inguinal hernias occurring? Well, there's probably a dysfunction in their pelvic floor, like the pelvic floor is shaped like a hammock. It needs to be reactive at the pressure of above, like a trampoline. If it's not, if there's a problem at the diaphragm and pelvic floor, level and looking at negative pressure, like the pressure's going somewhere, so it's shooting forward at the inguinal hernia. So that's an immediate sign that's why they need to be looked at for their breathing pattern and everything like that. But 25% in their lifetime, it's a hernia. A hernia has to have surgical repair, right? We can't fix a hernia. It's a hole in your tire.
Right.
Sometimes they leave umbilical hernias alone in the older population because they don't really I think they cause secondary problems with low back pain, and that's a whole other thing, but they leave it alone because of the mesh complications. But if they're getting an inguinal hernia, why are they not getting in? Because they have dysfunctional breathing pattern, paradoxical breathing pattern. Coming in for prehab would be an open market for us to educate the patient on what to expect from the surgery. And it's a high number population, so general surgery is doing that. So that would take us marketing that population. And there's already a validated article that's talking about prehab, and they've come out with a protocol for it. So we just need to get the word out.
Yeah. What does success look like for someone walking out of your talk? What do you hope that person, how have you changed their mind? What do you hope you take someone who walks in really not understanding what they're there to learn, but it looked interesting, they walked in. What success look like for you as they walk out? What is the change you're looking to create?
My goal for this presentation was, it's not necessarily, they're going to be learning some new information, just like what I talked about with you just now, like where you're like, oh, but they're going to be like, I already know what she just said as far as the skills, because we're laying out 12 different orthopedic approaches that are bread and butter with manual therapists. They're going to be like, I have more confidence now to connect the dots I'm not going to be fearful to treat someone with testicular or pelvic pain now.
Yeah.
Like, I'm going to try out this and see if it helps.
Yeah.
And have that gain confidence.
It's almost like permission. Like, they don't need it, but we do as a human seek that, oh, I knew that already.
Yeah.
If I just apply that familiar skill in an unfamiliar place, I could get great results. I could start helping these people that yesterday I didn't think I could, but I could have the whole time.
Yeah, exactly.
That's got to be pretty inspiring.
Yeah.
Yeah, that's great.
I'm excited.
Last thing we do on these episodes is what we call the parting shot. What's one idea, one soapbox statement or mic drop moment that you'd want to leave with the audience as we wrap up?
Don't be fearful to ask about any kind of issues with intercourse or sex at a party this Saturday night.
Yeah.
Get the word out.
I liked your line where you said, horse smells fear. It's like when you walk in that room, right? You don't need to know everything. That's the difference, right? Like, it's okay to be a little, be honest. Like, I don't know everything, but I'm confident enough to be able to ask, because the horse can smell fear.
Yes.
I like that. It's very, very true. Kelli, thanks so much for talking and for presenting here at AAOMPT.
Thank you.